Good evening and thank you, Divya. So, I'll be talking on red flags in OCT interpretation. When we look into the retina with an ophthalmoscope, we are actually seeing only the surface of retina. But we know very well that it is a complex 10-layered structure. But it was only with the advent of OCT that we were able to visualize all these 10 layers exactly similar to what we see in a histology, so much so that this invention has revolutionized the diagnosis and management of all ophthalmic diseases in general and retina in particular. And due to these numerous advantages, it has become the mainstay of retinal imaging. It is important that we familiarize with the normal layers and its reflectivity, which will help us to interpret the abnormal. So when we look into the OCT, we try to see if there is any change in the thickness, change in the contour, change in the transmission which we see posterior to the RPE, change in the reflectivity of the structures, any abnormal deposition, and we also look into the thickness maps for any quantitative analysis. We'll go through some examples. So this is a 54-year-old lady with blurred vision in the left eye and was suspected and referred as VKH from outside, but OCT showed the classical inner retinal hyperreflectivity, which is diagnostic of central retinal artery occlusion and which is an ocular emergency. And OCT is the most confirmative imaging method in this condition, and with the resolution there was thinning of the inner retina. OCT can so precisely document the microscopic damage that it has been used to stage the disease and also to predict the visual outcome in CRAO. This is another elderly male with defective vision in the left eye. Fundus examination was not very significant, but OCT showed a prominent middle reflective layer in the inner nuclear and plexiform layers with a dark gray paracentral zone in the near infrared image, suggestive of paracentral acute middle maculopathy, or PAM as we call it. It is due to ischemia at the level of intermediate and deep capillary plexus, not the full, it does not involve all the plexus like in a CRAO. It can be an isolated finding, and this is actually only a morphological diagnosis in OCT. It's not a real clinical diagnosis. It can also be secondary to various vascular conditions or systemic disease. So whenever you see this finding in a patient with non-specific visual complaints, we should investigate appropriately. This is something we are all familiar, a case with bilateral DME and responding to anti-VEGF. But I'm looking at this picture. This was also referred as DME, but if you look carefully, we can see that the edema is predominantly peripapillary and not macular. And this was in a young male who is a diabetic but not on proper treatment. Let's look into the OCT again. If you see carefully the infrared image, you can see there are a lot of sclerosed vessels, there is venous bleeding, all that which tells you there is something more than diabetes, and as expected, his BP was alarmingly high. So we did not even wait to take a color photo, sent him for urgent physician consultation. 2 months later, when he came back, this was a fundus picture and macular edema had resolved without any specific ocular intervention, and this was his diagnosis. So whenever you see such findings, systemic evaluation is so important. You can reduce not only the morbidity but even mortality due to these complications. This is another elderly male with bilateral DME. He was treated with anti-VEGF but no significant response. So we decided to take a break, told him to come after 1 or 2 months, but he could come only 6 months later with further drop in vision, more hemorrhages on the OCT, and significant worsening of macular edema with a huge amount of SRF. So I asked him what happened. He said he developed back pain, and after evaluation, he was diagnosed to have multiple myeloma. And in the OCT, apart from the significant macular detachment, we can see outer plexiform layer cyst, prominent middle limiting membrane, subretinal hyperreflective deposits, all findings very characteristic in myeloma. This is because the deposition of immunoglobulin light chains increases the oncotic pressure and draws more fluid into the subretinal space. And without any ocular intervention, the edema has almost resolved. So whenever you see unusual SRF, always try to rule out any coexisting renal disease or poorly controlled hypertension. Let us learn more about the fluid compartments. This is subretinal fluid, where the fluid is under the neurosensory retina, and it's a common finding in a range of conditions from AMD to vascular inflammations, etc. But when you see the fluid is under the RPE, it is pigment epithelial detachment, which is predominantly seen in AMD and pachychoroid diseases. This looks similar to SRF, but if you carefully see, it is a split within the myoid zone of the photoreceptors, and the fluid is also not as hyporeflective as SRF, which is typical of bacillary layer detachment seen in very acute inflammations and also in AMD. Fluid within the retinal layers with a cystoid appearance is intraretinal fluid, again seen in vascular conditions AMD, and this is precoroidal cleft, where the hyporeflective space is between the fibrovascular PED and the Brooks membrane of the choroid and is typically seen in neovascular AMD. So I'm showing you two cases, only the one eye with significant fluid not only in the posterior pole but also inferiorly. OCT is showing SRF somewhat similar with a thickened choroid. But here the choroidal layers are indistinguishable. There is significant RP, undulation, subretinal septa, all suggestive of weak age disease. Whereas in the second case, we can differentiate the choroidal layers. There is PED, elongation of the photoreceptors, all suggestive of CSR with exudative RD. And it is very important to differentiate these two, and for that OCT is extremely useful because high dose steroids is a must in VKH, whereas it is absolutely contraindicated in CSR. Again, this is a patient with CSR and a serous PED, but we look into the another section, we can see another finding, something like a double layer. There is a separation between the RPE and the Brooks membrane with a hyporeflective space in between the two layers, which we call it as a hyporeflective DLS, and this is commonly seen in CSR. This is another patient, fundus almost look normal, but it is only because of the OCT we could pick up the sub-SRF and also again the double layer with a hyper-reflective material between the two layers suggestive of hyper-reflective DLS, and Octa confirmed our suspicion because this was due to MNV and requires intervention. This, as we can see, is a case of dry AMD in one eye and advanced AMD in the other eye of the same patient. Is there any way from the time of dry AMD itself we can try to prevent this end stage? Yes, with OCT we can do it. So these are the findings: a presence of any subretinal fluid, intraretinal fluid, subretinal hyperreflective material or fibrovascular PED. These are all biomarkers which indicate that we should start treatment with anti-VEGF. Again, if you see very well-defined shrimp with foveal atrophy, outer retinal tubulations, atrophy of the outer retina and RPE, these are findings which tell you that it's time to stop the injections, and this also we must know. This is an elderly lady with vague visual symptoms, but it is only because of the OCT we could pick up the hyporeflective cavity and a temporal whitening, which is diagnostic of MACTEL. In fact, OCT is one of the earliest diagnostic modality. It also reveals other very characteristic signs of MACTEL like Draves sign, inner retinal collapse, hyperreflective dots with shadowing, and can even pick up the neovascularization, which is an indication, or in fact the only indication for intervention in MACTEL. Sometimes we get confused between these hyperreflective spaces. In MACTEL, they are more irregular with a lower reflectivity associated with retinal thinning because it is due to degeneration, whereas the cystoid spaces in DME are more circular or ovoid with thickening because it is due to vascular leakage. This is an elderly man who is on treatment for arthritis, and again it was OCT which helped us to pick up the parafoveal EZ loss, which we call it as a flying saucer sign and indicates HCQ toxicity even before the patient becomes symptomatic and any fundus changes are appreciated. FAF is also useful, but OCT is more easily available and it is very objective. This is a young boy, 17-year-old. He walked in just for his routine checkup. He is having low-grade myopia and did not have any complaints at all. But if you see, there are some vague RP changes around the fovea, but OCT showed extensive EZ loss. Whenever you see such bilateral symmetrical EZ loss, it is an indication to evaluate for inherited retinal dystrophies. And to our surprise, you can see his fields was tubular and gross reduction in the rod and cone responses in ERG, so which made us lead to a diagnosis of cone rod dystrophy. So to conclude, OCT provides a window into the depths of retina and optic nerve head. The high resolution and increased penetration possible with the newer machines gives us ultrastructural details which were never visualized before. It should not be interpreted in isolation but correlated with the clinical picture, other imaging findings and visual function. Identifying the red flags on OCT will definitely help us to institute prompt treatment and prevent visual loss. If a picture is worth 100 words, OCT is worth 1,000,000. Thank you.
Thank you, Dr. Lekha, for that excellent start. Ma'am, just one quick doubt, ma'am. Like in many peripheral centers which I have worked, Like they will have a baseline OCT system which will show only the macular OCT. So as doctors, we are forced to look that macular scan alone and treat. So isn't it important to look the whole area and then come to a diagnosis?
It's a very, very valid point. In fact, in some of the cases I showed you, like that CSR or VK, that macula section just showed SRF. But when you scan the other areas, we can pick up the RP undulations, the subretinal septae. So we should never interpret with looking only at one scan. And another point is, even if you get all the scans, again correlate with the clinical picture. If there are any other imaging findings, visual function, so considering everything only, you should make your final diagnosis. So maybe like to the patients also, we can explain that we have to repeat the OCT because of this reason, because they will be reluctant.
Excellent.
True, ma'am. Especially in cases where we see AMD or CSR changes, every section is important. It's not just foveal section. Foveal section can be seen in edema cases where you just see thickness. But if you have to see other details, definitely we need whole sections.
Nowadays, any fluid at macula is easily attributed to anti-VEGF therapy. So we have to look every section and read them as a whole, and then only we should come to a diagnosis. So thank you, Dr. Lekha, ma'am. Thank you for that.